Good afternoon, everyone. I'm here to present on the topic comparative assessment of the optical quality in small incision lenticle extraction and implantable columnar lens. For the introduction, both SMILE and ICL surgeries are indeed pro-game changers in the world of vision correction. SMILE Pro is a minimally invasive laser procedure that corrects myopia and astigmatism by creating a thin lenticule within the cornea for the precise removal, and it reduces the discomfort post-op. ICL surgery is involving implanting a biocompatible lens behind the iris and anterior to the natural lens, making it suitable for the patients with high refractive errors or thin corneas. This is a reversible procedure which provides excellent visual outcomes for patients who are not eligible for the laser vision correction. The parameters used in this assessment are the modulation transfer function to assess the optical quality, point spread function, and the root mean square values. For the MTF, quantifies how well a system can transfer the different levels of detail or modulation in an image or signal as a function of the spatial frequency. And why it matters? A higher MTF value indicates better visual quality, especially in low contrast conditions. It's important for understanding how well fine details are transferred to the cornea after surgery, which directly affects the sharpness of the vision. PSF describes how a single point source of light is represented in an imaging system, indicating the system's response to a point input and is expressed as a strial ratio. Why it matters? A sharp, well-defined PSF corresponds to clear, focused vision. A broader or more distorted PSF can indicate blurriness or optical aberrations, which can affect the clarity of vision. RMS is a deviation of wavefront averaged over the entire wavefront, and it is the magnitude of the aberrations. Why it matters? The lower RMS values indicate minimal optical aberrations, such as the higher order aberrations like coma or spherical aberration, which typically translate to clearer, more comfortable vision. Higher RMS values could result in glare, halos, or poor night vision. Both SMILE and ICL aim to provide excellent visual outcomes, but the success of these procedures can be assessed more precisely through these parameters. This was a prospective study conducted between July 23 and June 24. And we took a sample size of 50 eyes per group. The parameters were studied pre-operatively and post-operatively at 1 day, 1 month, 3 months, followed up using an eye trace. All surgeries were performed by a single surgeon. The inclusion criteria was corrected distance visual acuity of more than or equal to 20/40, more than 20 years of age, stable refractive error, myopia and myopic astigmatism. For ICL, the minimum anterior chamber depth was 2.8 mm. And for SMILE, the minimum calculated residual corneal stromal thickness were more than 280 microns. In exclusion criteria, any media opacity or trauma, history of previous ocular surgery, dry eye syndrome, glaucoma, pathological myopia findings, retinal diseases, history of prior systemic disease, pregnancy, and uncooperative patient. In the results, out of the 100 eyes, the 50 patients completed a 3-month study. All procedures were completed successfully with no complications. Significant differences were found between the preoperative and postoperative corrected distance visual acuity in the SMILE and the ICL group. In the SMILE group, MTF was lower at 1 month post-op but improved again at 3 months follow-up. And in the ICL, MTF was lower at first post-op day but improved at subsequent follow-ups. In the point spread function, in the SMILE Pro eyes, there was no significant difference at any follow-up. In the ICL group, PSF was lower at 1 month follow-up but it improved again at 3 months. In the root mean square values, in both the groups, SMILE and ICL, there was significant reduction in aberrations observed at 3 months follow-up. In the conclusion, both SMILE and ICL are effective surgeries in correcting myopia and astigmatism. They give comparative results as per the optical clarity criteria of MTF, PS, and RMS. And though the study showed better outcomes for SMILE Pro at 1 month post-op, but at the 3 months follow-up, both these groups showed comparable outcomes. Both these surgeries have good visual outcomes in quantitative and qualitative terms. And ICL is a better option for the patients who are not eligible for laser vision correction. These are my references. Thank you.
What was the refractive error in both the groups?
So in the ICL group, we took around, for the SMILE group, sir, it was not decided. But if the patient had IMI for more than -6 in ICL.
And in SMILE, it was lesser.
Yes, sir.
So did you do SMILE in one eye and ICL in the other eye?
No,
or
sir. No.
The patients underwent?
No, ma'am.
So do you think a high myopia can otherwise also have a little bit different varying PSF and RMS?
Yes, ma'am. It can happen.
Retinal pathology or maybe a little
Ma'am, we don't take patient with retinal
Not
pathologies.
pathology, but yes, due to high
Yes, ma'am,
refractive
they
error
can
itself.
differ. Yes, ma'am, they can differ.
If you then there will be a confounding factor
Yeah.
because if you are comparing two
Non-similar.
techniques, then the baseline parameters should be comparable in the two groups. That is one very important thing. Anything
Yes.
you want to say?
Yeah, I was going to ask the same. So, unless you have your patient data, original patient data, you haven't presented that.
Yes, sir.
So the original patient data, in all likelihood, does not match.
So for
So-
Between the two procedures.
Between the two procedures, the same type of patients, the same refractive error, same age groups, all that has to match to be able to compare this. If that doesn't match, this study just says, okay, that Smile Pro is equivalent to ICL. Doesn't mean much as a study.